recording today. Let's go ahead and take a look at chapter 11, corrective strategies for the foot and ankle. So, um, looking at it, if we're talking about our foot and ankle complex, we are talking about a couple different places, right? We've got our, talocrural joint, which I pointed out a little bit yesterday when we were talking about things. But, that is where you've got your talus sitting on top of your calcaneus here, right? And then where your tibia and fibula are meeting with that. And so, what can happen sometimes in people who have chronically limited dorsiflexion, or another way to say that is like chronic sort of hyperplantar flexion, although you don't really see it like that. So I mean, it would be like limited dorsiflexion. It's like they're not really gonna, I mean, it's not like they're walking around on their toes all day. They just sort of notice that they can't descend very well. So we have that. What can happen is, or if you had an ankle sprain or something, is this can get pulled out of alignment, and this talus can actually kind of slide forward. You can actually see like we call it an anterior glide. And when that happens, when you get that anterior glide, then these bones don't move around that joint correctly, and they get kind of stuck. They get like a pinching sensation. And it kind of just, when I say pinching, like normally you think pinching, you think like, oh, that must be so noticeable. That must hurt. It's like, ow, I got pinched, right? Not in this case. Like a lot of people are just like, yeah, my ankle feels tight. Like they're just kind of like, yeah, I guess that's the end of the range of movement. I mean, you guys have experienced that in normal ranges of movement all the time, like if I try to bend my elbow any further than this, like it doesn't really go any further, mostly because, there's not much more arm. But at some point, like it just feels like the joint's like, okay, like that's enough. This is hyperflexion, by the way, in the same way that hyperextension exists. That's just a fun mention of a term that I never get to say. Hyperflexion is a thing in the same way that hyperextension is a thing. But yeah, like you generally just feel like a pinching sensation, or like it'll just feel like bones like, nope, we don't go any further. And so like we need to be in order to be able to like restore the length of the dorsiflexors there, you have to get that talus pulled back into the correct alignment first. Can't even happen until the bone is like correctly, because they won't be able to get into a deep enough stretch to have that positive impact. And then once you can do that, if you do like a little bit of distraction and you kind of get that right into the correct alignment there, they can suddenly stretch so much further and so much more effectively. And then the body can sort of go, oh, like this is the range of movement I'm supposed to be in. And then you can strengthen the muscles around that ankle, and eventually that problem can sort of, you know, disappear over time. And again, what I'm describing right now is a great example of like, I'm not treating an ankle sprain and I'm not rehabilitating an ankle sprain, but I am treating posture. I'm addressing postural distortions, right? And that is the kind of thing that can then translate to so much more like positive athletics. I mean, like you have some, suddenly this person can, evert better and more effectively and invert better and more effectively. And so they can jog and run and pronate and, because you are supposed to pronate a little bit when you run, it's the overpronation that we're worried about. And so, like, this is a big thing, if we can restore that length. And so, we'll take a look at that there. We'll talk about like some, movements that tend to occur at the foot and ankle. So we experience dorsiflexion. We're also going to experience a little bit of like an unlocking sensation of the ankle, right? Like while you are descending into a squat, you can see, right? Like the big thing that nobody ever considers is that like you are going to get a little bit of um, this anterior movement here, right? Like, look, we are going into dorsiflexion. It doesn't feel like dorsiflexion because dorsiflexion, we think of this, like we think of like, I'm going up on my toes. I'm da, 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 that's what we think of. We think of, I said dorsiflexion, plantar flexion. Good Lord.
It's plantar flexion, yeah.
I'm so sorry. We're going into dorsiflexion during the descent of a squat, but like we think of this as plantar flexion, right? But like we think of dorsiflexion as pulling our toes towards us. That's kind of the opposite. Right? Like I go, you can't really see it, but like I go back onto my heels. But when you squat down, your shin comes forward, right? So that is very much like dorsiflexion. You're not necessarily like actively dorsiflexing, more like eccentrically descending into it. But like it has to happen. So if you have limited capacity for that, if those calf muscles are tight, what you end up with instead is that super, super upright squat. And then if you have that super upright squat, what ends up happening is you're going to fall backwards. If you try to keep your shins like perfectly level, and you guys can try this, do it like next to your bed or something, and just try to squat without like letting your shins come forward. Like I start to fall, like here's my full standing height. If I just go from here and I try to keep my shins perfectly upright the whole time, I fall about there, like instantly. So the way to fix that is to lean forward, right? I can totally lean forward, which is why there is a difference between squats and hinges, right? If you look, a squat versus a hinge, you just kind of pay attention to like our angles here, right? This is an example of like what we see. And don't get me wrong, like I said, I was kind of pointing this out yesterday because, Shantice, you're such a great example of it. But if you have like very long femurs, sure, you might have a slightly more upright shin here and there. But it still should be like there needs to be like that proper mobility there because you'll see like movements like this. I have nothing against a hinge. I do have everything against a hinge where you're freaking, if like he was holding onto a kettlebell here or something, like that's a ton of pressure on the low back. I do not love that. If you're going to hinge like this, the weight should be down here, right next to your shin, um, like in a deadlift. But look at the angle here to here. Like that's kind of what we're looking at. So that's one of the reasons why we see the excessive forward lean on individuals with tight calves. It seems very weird because it's like what we look at to spot an excessive forward lean is we're looking at like hips. But the cause of it is all the way down at the floor on the ankle. So, what you are supposed to do is like we have a little bit of dorsiflexion and abduction. And that unlocks the ankle, putting it into like this properly like loaded position, right? And then when we come out of that and we kind of put the tibia and fibula back in place, we're going to plantar flex, we're going to adduct, and that's going to kind of put us back there. So when we're doing this, as you're going down, we talk about like this proper dorsiflexion and abduction. This is where I kind of talked about this yesterday, and this note got, like I'm somebody who did this note a little bit too much. But you'll hear about like the claw foot, and like what that note kind of came from was like this idea that like you screw your heel into the floor. Like it's not just about like pushing your knees out when you're squatting down. You kind of like screw your heels into the floor, and that naturally pushes your knees in that outward direction, giving you like that proper like femoral position as you're sitting low into a squat. It is a good note. Like I do like that note. I think it's a very helpful visual for people that makes it very easy for them to understand. And you're getting your abduction, which is really good. But I will say sometimes it does result in how I do it when I'm not paying attention, which is like I'll literally like claw, like my toes will kind of curl under me sometimes, and that can limit your surface area. So what we look for in good squatting and just posture in general is this like tripod position of the foot. And what we mean by that is like you want to have good contact in all three of these places, right? It's not in the toes, which is the habit that I sometimes fall into when I'm like, if I go unconscious, not unconscious, but if I just go like, not paying attention, I'll like claw the ground with my toes. And so like here, and here. And that is going to give us the biggest triangle possible. The bigger the triangle, the more surface area you've got, the more surface area you've got, the better in balance that you are. And so you're not worried about like shifting that balance. What we can see sometimes is like we'll have the overpronators, and overpronators are the type of person who you'll sometimes see like are very heel dominant, right? Or you'll see like somebody who's very toe dominant, right? And so you'll see like these positions here where like there's a lot of pressure, it might be on that big toe, but like then it's also collapsing in on this ridge. Or see back here, and like sometimes you'll see like, very big on this outside ridge here. A good example of this is like I always talk about like foot contact. Um, let's see here. Oh my gosh, I'm forgetting the words that I wanted to Google. uh, eversion versus inversion foot contact. Um, no. Let's try pronator versus supinator. Yeah, that's a little bit. Oh, and this is another good way to do this. By the way, this is a great pro tip. Just outside of things, take a look here. This is really kind of a fun way to look at things. I will often tell my clients, let me look at your shoes. And you can look at the bottom of someone's shoes and see how they're worn. You can actually see, I'll do this for you guys. So there's my shoe, and you can kind of see it's worn out right here. This is my left foot, by the way, my left side. Outside of the foot here, inside the foot here. So you can see like this is pretty good. I'm actually pretty happy about that. I'd rather it be a little bit more centralized, but I'm glad that like we want to see wearing in the center here because that means it's distributing, right? This back here is, pretty common, also not too bad of a spot. But this ridge here is a little overly worn. And that is because I am a little bit of a more of a supinator. I learned a lot of, I tend to be a toe striker when I run instead of a midfoot striker, which really puts a lot of pressure on that outside ridge. Take a look at the right foot here. You can see the same kind of like wear and damage, right? Kind of dead there. And then like coming up here. So I'm happy with this section of it. I wish there was a gap right here. I wish I still had some tread here. And then like that's pretty common. But so yeah, that's our you look at a pronator and you'll kind of see the opposite actually. Uh, you know what I might do? She's gonna hate that I do this. I'm gonna go grab my wife's shoes. Be right back. It's the same shoes as me. um, yeah, okay. Kind of a fun thing here. Hers are a little newer than mine. I will say you can see lots of paint on the bottom of her shoes, though, which is classic. I actually don't see any marks. So these are too darn new. Ah, and these are as well. Ah, you can kind of start to see it. So here's her right foot. You can kind of start to see a little bit more worn down here and a little bit more worn down on this edge, but actually pretty well in the center. So happy with that. Not quite not as extreme of an example as I was hoping for. Now I'm gonna hoard all of her shoes in my office. But anyway, you look at the foot contact, it's not a bad way to look at it. And so when you see, ideally what we're looking for is this middle one right here, number B, right? I tend to be a little bit of a supinator. You'll see a lot of like pronators. They're gonna have like all this inside ridge stuff worn out. So ideally, the reason we like this one so much is it's that tripod position again, like you think about like why B is sort of like optimal here, and really the one we're kind of looking for is it's like you've got your pinky toe, you've got your big toe, and then like center of the heel there, right? And so it makes that sort of triangle that we are looking for with our contact. Um, so uh overpronation, oversupination, two things we want to be aware of that we're looking for. So then we'll also see a little bit of the subtalar joint. You look in here, this is the actual joint between the calcaneus and the talus. So last time we were doing talocrural, because I think I mentioned calcaneus last time. So you go here, talocrural, right here between your tibia and your talus. That's how it sits on top. Then you've got subtalar, which is just below the calcaneus. So this is the one. I don't know if anybody in here has sprained their ankle. This is probably if you have, this is probably the joint that you most affected. So you look at like an ankle sprain. The most the most common ankle sprain you're going to run into is going to be where someone quote unquote rolls their ankle. Oh, that's swelling. It's like that person swallowed a baseball and it worked its way to their ankle. Um, so sprains work the same way as muscle tears. You can see like you got normal, you got grade 1, grade 2, grade 3. Grade 3 is a full detachment. Grade 2 is, like a tear, and a grade 1 is like sort of overstretching. This is usually most people, they get a grade 1 or 2 sprain. It's not usually like crazy severe. Um, but the two that you're going to see are oftentimes going to be your ATL ligament that holds your fibula to the talus there. And the other one is going to be the CFL, you'll hear, but CL ligament, which is going to be right here from the fibula down to your calcaneus. And so this little bit right here, if you roll your ankle, that is the one that's sort of like most commonly torn. And so it's like, why? And this, by the way, I think you had a homework question in a previous class actually, and it said like, what is the most common sports related injury? And it is that lateral ankle sprain. It is where somebody rolls their ankle into inversion and then it tears, right? Now, why did it tear? Well, again, probably our most common postural distortion that we see is excessive eversion of the foot. So if you were to evert the foot, you're actually bringing your fibula down and you're bringing your calcaneus up. You're unstretching that ligament, right? You're shortening that ligament. And so you're leaving it in this like shortened position for very extended periods of time. And when that happens all day long, it gets used to being in that position. We go back to like Davis's law, we go back to Wolff's law, right? And it gets kind of stuck in that position. So then one day they step in a hole, they step in an uneven piece of ground, or they just roll their ankle somehow, right? And now this ligament that should have been able to handle this inversion movement can't. It's just not used to ever stretching, and so it just tears, right? It's very similar to ACL injuries we're going to look at. You get into one very common postural position, your body gets very used to it. One day you try to twist or turn, and your body's not really ready for it. And sure enough, like that ligament tears, just like a muscle would, right? I mean, I remember the first time I was like using that machine. I wasn't very good at like managing the cord for it, the tube for it. And so I just like held it the whole time. And I was like, da, 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 doing my thing. Like held my arm like this for like an hour. And then I remember like just dropping my arm when I was done. And I kind of just like dropped it really quickly. And like I had pain in my deltoid for like 3 or 4 days afterwards. Like it felt like I had done the hardest deltoid workout of my life and then just like ripped it in half. Like I didn't actually pull the muscle, I didn't tear the muscle or anything, but I definitely like, all of a sudden like just dropped and I was like, ah, and it wasn't like joint pain. It wasn't any of that. It wasn't like a rotator cuff thing internally. It was literally just the outside part of my deltoid. And it felt like somebody had just as hard as they could like hit me in the shoulder. And so it was like one of those things where I was like, what was that? And it's like, well, I spent an hour in a shortened position, you know. Uh Monday. I just saw this, Yasmin. It's copy pasting very quickly. I was like, why are you texting me? Because I'm a dummy. So but I kept it in like a shortened position for like an hour. And then when I tried to lengthen it out, my body was like, how do we lengthen a muscle again? Like just wasn't ready for it. So that is how we get a lot of these very common sprains and tears and things like that. Um, so we are not so, we should be able to invert, we should be able to evert, right? And we should have a good, relationship there, but we don't a lot of times. And so it causes, you know, damage of those structures if we're certainly very not ready for it. Causes injury, right? And then we have to take time off from playing. We have to take time off from all stuff. So we look at like our actions, right? If you're thinking of like how you're breaking down like the foot and ankle complex, break it into three planes, right? In the sagittal plane, you have dorsiflexion, which is movement of the ankle um, superiorly or towards the body, right? You'd be pulling your toes towards you. Plantar flexion, which we'd be pointing it away from you. Eversion, which is showing the bottom of your foot towards the outside of your body. You could also consider that abduction. We got inversion, which is showing the inside of your foot towards the inside part of your body. You could also consider that to be adduction, right? Excuse me. Man, I'm goopy. Then we got our transverse movements, which would be rotary movement. So you can move your foot and ankle this way, external rotation or internal rotation. And then we got our multiplanar or just like combo movements. When we refer to ankle pronation, we are referring to eversion, so eversion, bottom of the foot flattening in, showing towards the sole of the foot is showing towards the outside. External rotation, and a little bit, and this is the surprising one, a little bit of dorsiflexion. That one is the one that throws people off a little bit because it's like, wait, most people overpronate, and most people need to strengthen their dorsiflexors to fix their overpronation. That doesn't make any sense, right? So let's talk about that really quickly. Because it's like, why would they be dorsiflexing if they have excessive, or why would they need more dorsiflexion if they're excessively pronating, which involves a little bit of dorsiflexion? Like, why is that the case, right? Well, a lot of that is much more, it's not so much that they are constantly dorsiflexing properly, it's more so that they're keeping their weight in their heels. God. It's mostly that like they're just keeping all of their weight posteriorly shifted, right? And so like that is causing a little bit of dorsiflexion, right? But then they make up for like, they would be kind of back in a position like this all the time. So if they flatten their feet back down, right, the weight is in their heels and the center of the foot there, right? So what we end up like doing to sort of fix that is we work on our anterior tibialis and our posterior tibialis. And the anterior tibialis is going to be straight up working on like dorsiflexors that also help with a little bit of foot inversion. And then we work on the posterior tibialis. The posterior tibialis is another muscle that is sometimes a little surprising to see on our we want to strengthen it list because it's a plantar flexor. Your posterior tibialis actually helps plantar flexion. But its big job is mostly inversion, right? So what we're trying to do is we're trying to restore this, this optimal alignment so that we're not getting the synergistic dominance that we were getting before, right? We're using our, and like, don't get me wrong, your calves are definitely your main plantar flexors, but they do have this synergist in the posterior tibialis that's supposed to be helping. And, so what you're supposed to see is like when you are going up on your toes, you're doing it in a way that's like still balanced rather than doing it in a way like you guys can try this at home right now. Really feel, ground yourself on the floor. You do this barefoot is probably a little bit better. And just plantar flex right now. And do you feel that in your whole calf? Or do you feel that like primarily just like on the outside part of your calf? Then what you can do is you can try and spread your toes and almost invert just a little bit. So like, almost like keep the weight to where like really like reach out with your pinky toes, like reach out with those pinkies and ground those into the floor, and then try to do that again. And you might notice that like you feel a better distribution of weight in terms of how that's pressing on your calves. And so it's like now you're still using soleus and gastrocnemius. Like they're kings of the show here, right? But you're getting that synergist, that posterior tibialis, a little bit more activated, and you're allowing it to do that little bit of inversion, which is going to recenter your foot a little bit. Which is again where that whole screw your heels into the ground note kind of came from. Was this idea of like getting a good base, a good strong base, a good strong foundation, so that we can, supinate a little bit more. Most people tend to overpronate. Like I said, I take that note a little bit too far because I tend to be a little bit of a supinator. I don't have high arches, but I definitely sort of have overcorrected over the years of like working with people on this. Um, and like working on myself as well. And so like, you look at your inverters, you've got your anterior tib, your posterior tib, and your soleus. You look at your everters, right? Gastrocnemius, peroneals. And then that peroneals list. And that peroneals list is also very, very tight. We haven't even talked about that yet, but like the peroneals, the longus and brevis in particular. Back up here. These muscles that are running over the top of the foot, they're making this like connective tissue band there. That's not what I'm looking for. Let's go with that. They are directly everting, so they're literally pulling your foot so that you can collapse that arch down onto the ground. So that is oftentimes a muscle we want to stretch out. It's an easy muscle to stretch out, peroneals stretch. Easiest stretch in the world. Take a seat, grab your foot. But if you have a client who is like really like following those arches, Trisha, this is a great one actually before your runs. And you don't have to do that, but you have to do like the seated one if you want. Do the foot drag one. That one's not too difficult either. Where are you? Come on. Somebody's got to do the foot drag. It's literally the easiest stretch in the world. Standing. Are you kidding me? That's so funny. I mean, you'll see, I guess that counts. I don't like that as much, like with the leg out in front like that. Yeah, there we go. That's the one I'm looking for. So see how his leg's coming back behind him?
Yeah.
He's kind of like flopping that down.
Yeah.
Basically, you just invert your foot. Easy. I mean, honestly, I tell people like just hold something and just like put your pinky toe on the ground and just drag it. Give it a little gentle drag there. And you'll feel a good stretch on top. Or you can just sit there, and grab your foot and pull your foot, pull your pinky toe around and towards your face. It's not coming all the way up there, but give it a nice that before a run really, really great if you're an overpronator. I don't know if you are, but if you're overpronating,
Not severely, but some, not
yeah.
severely.
So that could be a really good one. And then just like a couple, like, reach that pinky toe out and then do just a couple of those little like soleus presses can also be a good way to kind of get things activated the way you want before getting on a run. If you're a midfoot striker, if you're a heel striker, it won't do much for you. It's not going to hurt you, but it won't do as much for you. But yeah, so pronation, supination, these are things that have to happen during a squat, right? What we tend to see is we see a lot of this pes planus syndrome where we're kind of collapsing the arches down, or we see pes cavus syndrome, where we see the pinky toes kind of claw on the ground there. We see this kind of exaggerated arch. And so muscles we need to be familiar with, anterior tib, posterior tib, and soleus. You can see that's in our notes right now. So actually, I'll just go like this. And then we see our everters, gastrocnemius, peroneus longus, and peroneus brevis. Tertius is on there as well, but not as common. So what ends up happening is we can, if we're doing this, and here's the hard part, right? It's like, does this travel up and affect the hips in the kinetic chain? Or what if there's hip dysfunction? Maybe my feet and ankles, maybe they're in great shape, but I have a job where I'm sitting all day and my glutes and stuff are getting tight. Does it travel up and affect my glutes, or do my glutes travel down and affect my ankles? Yes.
The great question. The great question I'm always trying to figure out.
Yeah, it's both. I mean, if all of this is like linked together, it's a chain, right? You know, it's a chain. If this link's messed up, it's going to affect this link. Well, what if the messed up started over here? It's going to affect this link. You know what I mean? It totally goes in both directions, right? So, this can poorly align. Your foot pronation can poorly align things, and that can cause this excessive, hip dropping and hip hiking. You get that like excessive movement. I usually spot this, not even, I'll actually know to look for ankle dysfunction by paying a little bit more attention to the upper body sometimes. Like if I don't just see it, or if I don't think to check, or, something is just in the way mentally, or if I just don't get there yet. And I know somebody who runs like this. I see people sometimes who like, yeah, they really have this like crossbody run instead of like arms a little bit more forward, right? That's a sign that there's a lot of like extra trunk movement. Number one, highly inefficient way to run. Now you're sending energy that way, and you are trying to travel that way. It doesn't look like much. I mean, at least I'm not sending energy back that way, but like still not great. But I'll be like, oh man, that's like a lot of cross body movement. So I'll look for like hip dysfunction and then travel down and look for knee and ankle dysfunction. So that can be sometimes a sign of that. Um, or it can be that it's straight up leading to it, Um, which came first, the chicken or the egg? Like either way, you're gonna get a chicken out of it. So there's static malalignment.
I
Obviously,
know you're going to get a chicken out of it.
yeah. There's static malalignment of just like being in the wrong position all day long. And then what that causes is like, again, abnormal muscle activation. You start using the wrong muscles to get the right job done, and then eventually we have full-blown dynamic malalignment, which is like, yeah, as you sort of like move through a range of movement, you're not moving effectively, right? So the two big ones, we talk about this regional interdependence model, aka your toe messes up your shoulder, or your nose messes up your knee. The idea that we're all connected everywhere. We have overpronation, oversupination here, right? So we see excessive pronation during and we say like a closed chain dynamic movement. All that means is we say closed chain, it means like contact with the ground directly. And then that results in just, bad foundation, right? Oversupination, same problem, except that it's increased inversion instead of increased eversion. And again, dynamic movement. And then that oftentimes leads to, in this case, it's usually like hip tightness. A lot of times, like overpronators will oftentimes have like the knees caving in, tight adductors, and weak gluteal muscles. Oversupinators will oftentimes have like tighter glute muscles, usually tighter hamstrings in general. They make pretty damn good sprinters, but they are also the high risk. You're going to tear that hamstring off the bone sprinters. um, so, things that we tend to, these are just like common trends. So let's go ahead and hop over to everyone's favorite YouTube channel. um,
Squat you.
oh yes, of course. Always, always, always our favorite. So, not the top three exercises. I do love that. But talking about how to fix tight ankles. Obviously, the one thing about Squat University is like it is very it's it's very squat centric, but make no mistake about it, this very much applies to everything. So, assessment results, as we're looking at things, again, we're going to see in static posture, we'll sometimes see the foot turn out, feet externally rotated. We'll see that lower leg posteriorly displaced, aka we're going to see that occasionally we'll see that sort of hyperextension of the knees as well. That sometimes happens if you are not like effectively and properly like grounded, you will try to create stability where you can. Locking out your knees can be an example of that. We'll see pes cavus, which is that inversion. We'll see pes planus, which is that eversion, and we'll see pes planus distortion, which is like the eversion plus the external rotation plus the knee valgus. So most common one that we see right here, pes planus distortion syndrome, aka pronation distortion syndrome, whatever you want to call it. And I'm gonna pull up that classic chart that you guys have seen a million times. No, not that. Where's my? There it is. So when we're looking at this, right, we're seeing in red, these are the things that are happening too much. In blue, these are the things that are not happening enough. So we see excessive hip internal rotation. So your femur is internally rotating, which is changing the direction that your kneecap is going to face. So your kneecap is going to face inwards. We are seeing tibial external rotation to compensate. So this rolled in, therefore this rolled out. Now the ankle is also going to roll in. So foot pronation. So tibial external rotation, foot pronation, and then in the femur, hip internal rotation and adduction. So the femur's coming in and rotating in. So these are the muscles most responsible for that. That's your TFL, literally its main job, hip internal rotation. It is also a hip flexor, but this is what it's doing a lot of times. Adductor complex is doing adduction, no surprise there. Now the biceps femoris short head is a tibial external rotator. So it's weird that this outer hamstring muscle is causing the knee to cave in towards the inside. I get it. Like the adductors were so easy. It's like my adductor is in, and so it pulls in. That's real simple. It is weird that an outer hamstring muscle is pulling the knee in. But again, it's not so much doing that as much as it's turning the foot and like all the way from the shin down out. And so like the tibia is externally rotating. That's literally that biceps femoris short head's job because it only starts in the middle of the tibia, middle of the femur, and inserts onto that outside there. So it pulls this way. And then you've got your lateral gastrocnemius working with that biceps femoris, your soleus, and your peroneals especially, everting that foot directly. So we need to strengthen all the antagonists to those muscles, or we need to strengthen the synergists that were supposed to be doing their job to those muscles. Like posterior tibialis is not like it's not like an antagonist to the gastrocnemius, but it is the synergist that was supposed to be doing more work. So gluteus maximus, that's going to do hip external rotation, directly the opposite of the TFL. Gluteus medius is going to do abduction, directly the opposite of the adductor complex. Medial hamstring is going to do that tibial internal rotation. That's directly the opposite of the biceps femoris, even though they're synergistic when it comes to knee flexion. These muscles, totally synergists when it comes to bending the knee, totally antagonists when it comes to rotation of the knee. And then we're going to see medial gastrocnemius. Again, synergists when it comes to like plantar flexion, antagonists when it comes to internal or external rotation of the ankle. Anterior tib and posterior tib, opposite of those peroneals. So that's a general pes planus distortion, right? So we see like if we see excessive pronation or feet turnout or heels rise, any of those are kind of direct ankle problems. We'll also see the excessive forward trunk lean coming from tight calves. And the way that we tell if it's a calf problem is if elevating your heels during the squat makes your squat easier, that tells us you've got those tight calves. So there's our transitional movements, right? Feet turn out, heels rise, or excessive lean, limited dorsiflexion there. Single leg squat, same thing. I was like, that's not the single leg squat. That's a single leg squat. So you see the knees cave in, right? Means soleus in there. We see the foot turn out, or we see the heels rise. In this case, foot pronation during the split squat, if you need that progression there. Depth jump. I will say this is not covered really well in this PowerPoint slide. But if you're doing a depth jump assessment and you notice like the feet turn out, sure, like that one's pretty obvious. If you see the feet collapse in during the depth jump, remember that video I showed you guys the woman, she's doing like the less test with her son. Um, and we watch him, and like you can see, it's really easy to tell that he is like overpronating. Boop, 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 boop. Skip, 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 skip. Let's go to his front view here. So you can kind of see that, right? Like obviously he's landing. Um, right. He's already got a little bit of foot turnout. Knees caving. He's also shifted, but see how the knees collapsed in and then like his foot fell right before his jump. So kind of coming back to that. Watch his feet. Whoop. See how like whoop, 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 it falls right as he's like transitioning and jumping back up. If I can slow this down. Um, Playback speed. One more. So watch. He jumps, and you can even see it at the beginning of his jump right there. See? Feet flattened in, knees caved in. And then he lands, feet flattened in, knees cave in, and he jumps. Um, so one other thing you'll also see with that that's not covered well in our slide here, watch his instincts here. So we know he's pronator, but see how much weight he had like going forward there. He's able to hold it on that one. But watch what happens. I think it's this next rep. I've watched this video like 10,000 times. It's just a really, this is like some mom at home and just like made my favorite video on the freaking internet for showing this test. Like so grateful for this. But look, see how far like his heels like they're barely staying on the ground, all of his weight's coming forward. He's got that excessive forward lean. So kid's probably going through a growth spurt and probably just like shot up overnight, and so he's got these like calf muscles that are like not really ready to be as long as they are. Watch this one. I think this is the one. Yeah, see how he even steps forward, right? So he should be able to like land and sit back and dorsiflex, but because he can't, he's like all of his weight's coming forward. He's gonna fall forward, or he's gonna shift his butt super far back, or he'll just pop his heels up. And then when he pops his heels up, when your heels are up in a position like that, that propels you forward. That's the whole theory behind toe striking when you're running, by the way. This idea that you're forward pushing the whole time. And so like you can see like the instinct is definitely there, or the balance is definitely there to like propel him forward. He's like struggling with that because he's supposed to jump straight up. So you can see him like kind of stop and try to fix that. Um, it's not really mentioned here, but that is something to kind of pay attention to on that if you do a depth jump. And guys, honestly, I haven't done a depth jump assessment with my clients in years. Like I'll do box jumps and then pay attention to them once I give that to them like as an exercise, or I'll do a depth jump as an exercise, but I haven't done it during an assessment since I was like starting out. Just because you'll learn what you need to learn from the overhead squat. So in terms of direct mobility assessment, we got a weight bearing lunge test, which is, you can lunge and see like, yeah, it's the same as your split squat assess. You can do a straight up mobility assessment, check for ankle mobility. Do they dorsiflex correctly or not? And then also sometimes paying attention to that first metatarsal extension. You should be able to, while on the floor, with your foot like spread and extended, you should be able to lift your big toe up. I guess that's my thumb. You should be able to lift your big toe up off the floor. Like that should be able to happen by itself. If you can't do that, if you don't have that metatarsal extensibility, that is showing that you probably have a relatively stiff foot. And again, that is something that like you can literally just like that's one that you can work on. Just spread your toes and pull that toe up. In fact, people with plantar fasciitis, that's like the first piece of homework I start giving them. I'm like, hey, like until we get into the gym, but if you have like, a little bit of, if you think you have plantar fasciitis, but it hasn't been diagnosed yet, something that I know won't hurt you, that is just generally good. And it's good for plantar fasciitis, but it's also just good for humans in general. Just get in there and just like spread your big toe out, pull it away, get in the gap and give that a little massage, lift it up, give it a little massage in the gap. Like literally you're just gonna lift it and then get in that little webbing. Like there's more webbing in your hand. It's a little easier for you guys to see right now, but literally just a little bit of like metatarsal extension, really good for your foot. actually, Trisha, after a run, it's another good one that could just give you a little bit of, just like, you can be real dirty, real dusty. Wash your feet first. But like,
I roll out my feet every day,
yeah, yeah, it's
and
pretty
when
cool.
I'm especially when I'm into running,
Hmm.
I wear toe spacers
Oh, do you? Oh,
in
great.
my slides. I
Absolutely.
saw it.
Great.
I made sure my foot will fit in my slides
Amazing.
with the toe
I
spacers on.
I love toe spacers. Huge fan. Um, they will
I have them on
ruin.
right
What's that?
now. I'm wearing them right now.
Oh, are you? Yeah, they're amazing. They will ruin your ability to wear high heels, ladies, forever. But man, they are so good for your posture.
And
Lindsay,
I've been taught that technically you should be able to wear toe spacers in your shoes. Now you never would, but that's how
right.
wide your toe box would be.
Yeah, that's a really good indicator, actually. Yeah, Lindsay has complained about that a few times. She's like, "You made my toes wider." She's like, "I can't get in my high heels anymore." I'm like, so here's our crappy list. I shouldn't say that. Here's the list that I don't care too much about, but this is just a general, like, generally, if you have healthy foot and ankle complex, but you're looking for some things to throw just into a healthy warm up, any of the things on this list are good. These are all positive, net positives, but again, none of them are specific. So here's a list of things that you can do as inhibition slash lengthening techniques. Inhibiting up here in the SMR, lengthening in the static stretches. Um, I don't like a general list. Here's some generally good core exercises. Here's some generally good resistance level exercises. So that would be really good for activation in core slash balance, be really good for integration in resistance, and then back to inhibit slash lengthen in the cool down. So this looks like if you wrote like a foot and ankle day, and it's like, here's 4 exercises there, 4 exercises there. This could be a generally good, imagine if there's a foot and ankle day, like in the classic like bro split, like chest, back, legs, foot and ankle. That's kind of what that workout sort of looks like. But what I like way better, getting specific. I do have links here, um, but these links sometimes break. They're not always perfect. But here's a good, if you get a foot turnout, really you're just looking for SMR on the calves, right? Particularly the lateral aspect of the calf is going to be a big one. And then I put a pin and stretch up here. This is a bit more of a dynamic hamstring bit. Pin it with physio ball or pin it with a foam ball. And then once you find that, like, this is already just good SMR for the biceps femoris in general. You do need to be elevated to be able to do this because, floor will be on the way. But then what she can do is she can lengthen. And the way pin and stretching works, it's a little bit different than like you think about like what foam rolling is, right? Do I have a cylinder of any type around? Yeah, yeah. So foam rolling works like this, right? It's like I'm rolling the roller over the muscles of my forearm right now, right? Pin and stretching works a little bit differently. It's like I hold the roller in place and I move the muscle along it. You know what I mean? Both are good. They're both kind of doing the same thing, busting up fascia, promoting blood flow, all good things. But I put that one in there particularly, is it an inhibition technique or is it a lengthening technique? Yes. It's a gray area for NASM. NASM doesn't have an opinion directly on pin and stretching. I don't know. I think of it inhibition. I guess it's kind of lengthening because it's like an active stretch. You can see here 10 to 15 reps, 1 to 2 second hold. So I don't know. It's a lengthibition technique. I don't know. Then we got 2 straight up static stretches here, gastrocnemius and biceps femoris. You're static stretching your BFem. It's really simple. You just bring it up, go across the body, and straighten that out. And you can see, left leg to right shoulder. You go across your body. Now, in terms of activation techniques, we want to make sure that we're activating our medial gastrocnemius, right? So we can see under activation, the muscle we're targeting, medial gastrocnemius. So a calf raise with the toes in, just an ever so slight toe point towards each other. Very, very helpful for that. There you go. Actually, he's doing a great. Oh, it says pointed. Yep, perfect. So just a little toe in there. That's going to get that lateral aspect of the gastrocnemius instead of the entire thing. A dumbbell hamstring curl. This is a fun one. You can see he's going to go on the machine there. By giving this, he's sitting on this like a little foam pad. That just gives him a little bit more angle. Um, but right there, and then by squeezing in like that, he has to hold the dumbbell there. That creates this like inward squeeze. By doing that, that actually targets the medial hamstring a little bit better, rather than like you let his, knees come together and his feet turn out like this. Well, then guess what? That's tibial external rotation. Now you're using your hamstring, but you're using the biceps femoris. Totally the opposite of what we're aiming for. So by heels together like this, he's kind of doing the opposite, right? He's able to spread his knees out a little bit. Again, we're going from here to here with the knees. And then lunge to balance is just a very good integrated dynamic movement. It's a balance exercise, so a lot of like integration there. And then obviously, using glutes, hamstrings, calves, it's just a total body or compound movement integration exercise. So once we get the right muscles turned on, now we can get those right muscles to work in conjunction with everything. For overpronation, it's just like a lot of this is going to be similar to the feet turn out. It's just now we're seeing a little bit more going on there. So we're going to see same thing, calves, but this time we're probably going to get a little bit of SMR for the peroneals in there. So just laying on the side of the foam roller there, getting into, the outside aspect. He's going right at the top of the knee. I think you can also go, yeah, like right here down about midway or maybe just above the ankle. Depends on where you're tight. That's one thing about foam roller. It's like, where do you put the roller? It's like everybody's a little different. TFL is a big one. TFL because pronation is again, it could be that it's caused all the way at the hip. Hips causing the internal rotation, that's causing the tibial external rotation. It's just traveling down the kinetic chain. So a little bit of TFL action in there can help with that. So foam roller on the pocket, guys. And then static stretches for each of those. Working on our dorsiflexors, trying to strengthen those. Just going to pull this straight towards her face. Direct dorsiflexion. I will say she's a little loosey-goosey for me, but this is just my best demo that I can ever find. I'd like a little more pause in between each rep just to really like get that mind muscle connection. Side lying hip abduction is a fantastic exercise. The one thing on this that I would say as a coaching tip that a lot of people forget, she's doing a good job. She's abducting. That's fine. But if she can push that back just a little bit, like if she can go into hip extension just ever so slightly, that's going to be a little bit more effective. This is why you'll sometimes see like wall heel slides. And a wall heel slide is totally just a side lying abduction. But it just ensures you can see like his hip is more forward. Like there's a gap between the wall here, but that ensures that he's doing a little bit of hip extension, just definitely targeting the glute. Because sometimes when you're doing abductions, you can get your TFL, your IT band, and then step up to balance, this is just an integrated leg exercise. And then for heels rising, this one's easy. Tight muscles, soleus. Now, I will say a little bit of relief in the quadriceps can be helpful there. I did put SMR quadriceps. This is brutal. I don't know a lot of clients that will want to do this. It's not because the quadriceps are tight that foam rolling them can be so brutal. It's just because there's not a lot of space between the muscle and the bone. So you're pinching two very hard objects. If you are going to do a foam roller on the quadriceps, I'll recommend like a softer roller. But like, I haven't even seen one of those softer rollers in a gym in years at this point. Like the white foam rollers that are like softer foam, those just like nobody uses those anymore. Like There's not around. And it's because they break down too quickly, so gyms have to buy them more often. The dense ones last longer. So it's not because they're ineffective. It's just you end up spending more because they degrade over time. Um, but I mean, foam rolling your quads is brutal. Your clients will yell at you. And then a standing quad stretch is the only time you'll pretty rare that you'll see me give somebody a standing quad stretch. I think this is mostly useless. Not a lot of people really need this, even though it is a very popular stretch. Um, and somebody with tight hip flexors, sure, occasionally, but even then, now it's just like you're not really stretching your hip flexor, you're stretching your quad. Um, Resisted dorsiflexion, like it's directly the antagonist to the soleus. So no surprise we're seeing that again. And then I went with a single leg squat for our integrated. You guys know single leg squat. So that is three simple programs that you can do for various ankle dysfunctions, and then a master list of things that are just describing to you, sort of which must. I mean, like these are generally good ankle stuff. But again, just I encourage you guys, like, don't write general routines, write specific routines. So if you got a client who has a history of plantar fasciitis, Achilles tendinopathy, which are kind of the same thing, just the pains in different places. It's inflammation of the plantar fascia or inflammation of the Achilles tendon. Medial tibial stress syndrome, fancy way of saying shin splints, or ankle sprains. Any of those, all these exercises on this list are all going to be very helpful. So you guys have that in your notes, but I guess if you want the hyperlinks here, let me put that in the chat as well. Chapter 11. You guys can download chapter 11 there, and it'll have your links. Let's go ahead and knock out chapter 12 here. I think I had like a modified notes first. Yeah, I had the foot and ankle plus the knees. So I don't need that. Where did my notes go? Knee stuff. All right, knee stuff's a little easier. The joint's bigger, um, but and there's actually a couple more injuries. But for the most part, I think the knees are actually a little easier to understand. As big of a joint as it is, and as commonly injured as it is, it's pretty darn simple. You got in terms of motions, you've got flexion, you got extension, and you got internal external rotation of just tibia by itself. So not as much going on here. Um, so when we're talking about the knee joint, we're talking about two major joints here, the tibiofemoral. So your tibia interacting with your femur. That's kind of the knee joint proper, like it's like this big bone coming down here, right? And then like the bone that it sits on, creating this kind of ridge up here, right? And then you get your fibula over here, just kind of comes up and kind of hangs out. So there you go. And then you also have your patellofemoral joint. So, femur's here, tibia's here. That's tibiofemoral. And then we have our patella sitting on top of this whole thing. And there is our so patella bone, femoral joint. So patella with femur. So what's interesting about your patella, and this is a great picture. Like we never look at it like it's this gap, right? Like your kneecap is not attached to you directly. It is not directly, glued together the way like a lot of other joints in the body are, right? It kind of just sits there and it's embedded within this other connective tissue, right? So it needs to be able to actually slide, and that's a good thing that's not attached because it needs to be able to glide up and down, a little bit of lateral movement. It needs to be able to actually move. And so we'll see we've got flexion and extension. Now, you'll see some things that should be able to happen, but don't necessarily need to happen too much. We want to have a little bit of anterior posterior glide. You should be able to grab, like if you're stabilizing your femur, you actually grab your tibia and kind of pull it, it'd be sitting on top like this. You kind of pull it front and back. But it's not supposed to do a ton of that. And it's certainly not supposed to do one and then get stuck there, right? So that's one thing that you'll kind of look for. Tight hamstrings can cause that, or tight quadriceps can cause either posterior or anterior gliding. It's one of the things they look at. Yasmin, I know you like to stand with like the kind of hyperextended knees, right? That's an example of like that posterior shifting, right? So the nice thing about like your hyperextended knees, it means you probably have pretty loose hamstrings, right? But it could also mean that you also have really tight quadriceps. So again, I don't typically do your classic like quad stretch. For you, I might though. But that's where we got to look at a specific mobility assessment to kind of look at that. Internal external rotation. Um, you know, so there's a lot of like motion, this is a big joint with like a lot of gliding that happens. That's why we have our meniscus there to kind of reduce that impact. Um, but for the most part, we're looking at like the bones that are going to affect us here. We're really just paying major attention to the femur, how it's interacting with the tibia there. And then we are going to pay attention to what's going on in the hip, so pelvic stuff, and also like ankle stuff, right? If your ankle is dysfunctional or if your hip is dysfunctional, your knee's caught in the middle. It is between a rock and a hard place. I know I said it a lot, but we will see some common injuries associated with dysfunction in those other joints. We'll see injuries in the knee area because of that. So we'll see things like patellar tendinopathy. This is inflammation of your patellar tendon. This is sometimes referred to as jumper's knee because maybe your quadriceps muscles get a little tight. Maybe your quadriceps muscles get a little bit tight, and then that causes your kneecap to glide in one direction or another. And so you'll get this like kind of pain or swelling just below your kneecap, usually right in here, right? Call that jumper's knee. That is one, again, I will actually sometimes give your classic like quad stretch to. Somebody like that, I totally use on. And then I do a lot of things like wall sits. Wall sits in particular have been shown to be really good for patellar tendinopathy. But at the end of the day, I'm going to need to address the fact that they're using their quads more than their glutes. So I need some glute activations. I need to inhibit those quadriceps muscles, and I need to work on their knee stabilization. We'll also have patellofemoral syndrome. Now, instead of just getting pain at the bottom of the patella there, this can happen where they get a pain or rubbing sensation in the knee in general. My mom calls this creaky knees. And, again, this is where, where's let me see. I'll go poor patellar tracking. That usually pulls it up. I mean, here's a full-blown dislocation. Certainly wouldn't be this. I mean, but again, like just it's a full dislocation just means it's not going to glide back on its own. That's poor patellar tracking for sure. It's just a very extreme version of it. But you'll see if your patella is, let's say sliding, gliding medially or gliding laterally or superiorly or inferiorly or any combinations of those, right? These are all attached to muscles. So it could be that like, I mean, think about it, right? Let's take copy that. And let's just draw some quadriceps. Let's draw some quadriceps muscles over top of this, right? So we'll put the vastus lateral. We'll start with the vastus lateralis here, right? So maybe we'll go like like this, right? Now we'll put the vastus medialis in there, right? So maybe we'll go like that, and we'll put the vastus intermedius in there. Right, so we'll go in the middle, and then we'll put our rectus femoris over top of the whole thing. Kind of, kind of like that, right? So now it's like we're seeing, okay, well, kind of looks like a quad, you know, kind of. Looks like a a big bodybuilder. But like imagine like if your lateralis is too tight, well, that's gonna pull this way, right? If your medialis is too tight, which you don't meet a lot of those, we're gonna see that one, right? And we see anything in the rectus femoris, right? Or if we see the vastus intermedius. These two not as common, but like this one, man, tight freaking vastus lateralis, super common. Because again, your vastus lateralis shares so much. You get a client with knees caving in, right? That vastus lateralis is really tight. I mean, here's a great picture right here. Like, look at this. You can see, man. Um, this is all. Look at all this like fascia. You know what I mean? Actually, let's get a better one. Lateral knee fascia. There we go. This is a good picture. Look at this. Like you can see your vastus lateralis coming in, and then it's like all this like it's got its insertion points, and then you have like the IT band there. You get the biceps femoris on the backside, like all that sticky fascia, getting tangled up and tight, especially if your knees are constantly caving in. And then what happens? Well, your kneecap pulls this way, and then yeah, and when I say I'm not saying you're dislocating it, but it's rubbing. It's not rubbing the way it's supposed to. So you're moving your knee. You go like this and moving it back and forth. And it's like You know, that's your patella being like, I don't fit here anymore. I've been pulled out of my ridge. And then IT band syndrome or runner's knee, which is what I thought we were talking about yesterday. Is what I thought you were going to say, Trisha. It was like your lateral knee pain, but you're talking about like you sometimes get like that medial sensation. That is probably more likely. It could be a patello femoral thing. Maybe your kneecap is gliding inward
So it
instead.
could be kind of the jumper's knee.
What's that?
So
Not
kind
jumping.
of the jumper's knee.
Patellar tracking. Patellofemoral.
Okay.
Yeah. So it may be tracking inward a little bit, so you're feeling a grind on the inside ridge. And if that's the case, then that is where you are the, no offense, weirdo. I don't see as often. I closed it. Where the VMO is a little bit tighter. I still have my hesitations, but I just don't see it very often. So I would say, you know, but yeah, that's where we get into mobility assessments on Thursday. We'll look at the specifics of that, and we'll learn a lot more. But yeah, if it's tracking poorly and you're feeling a grinding sensation, it causes inflammatory response. That inflammatory response causes aches and pains. Or it could just be like your stabilizers, right? Again, we look at the sartorius here. The whip. It's running from here all the way into here, you know. So if it's getting inflammation along that ridge, and that's what I would jump to if I were making a really quick assumption, just because I know you're a long distance runner. So long
Right.
distance runners, 90% of the time, I'm looking straight at muscles, like I'm looking at like dysfunction and particularly in fascia. Like I'm looking at like the stuff that's just like rep, a million reps, you know what I mean? So something like this is what makes the most sense to me. But we will learn more tomorrow. um, so yeah, key muscles of the knee: gastrocnemius, soleus, adductors, hamstrings, IT band, quads, and glutes here. Sartorius, I'd put on that list as well. Just, again, our stabilizers, gracilis, I guess that falls under the adductors kind of, but so yeah, as we sort of move through it, we'll see some dynamic malalignment. Usually the big things: knees cave in, knees cave out. So pes planus syndrome, we're going right back into this. Again, adduction and internal rotation of the femur there. And then we'll also see that knee hyperextension, that locking out of the knee. That's another really common one. Knee varus, totally the opposite. Knee varus is the knees caving out. So that one is definitely not as common for us to see. But if you see somebody with like knee varus, that means that they actually probably have a tight medial glute. So we finally got the glutes on a list of like tight overactive muscles. Not the gluteus maximus though. It's probably just that lateral aspect, gluteus medius, and then probably the piriformis doing a little bit of work there, synergistically dominating our glute. Remember, the piriformis is doing external rotation. Gluteus maximus is supposed to do most of the external rotation, but sometimes you'll get that, and that's where, and a lot of people who have knee varus, they'll sometimes get sciatica symptoms, you know. And it's like, I don't get it. I've never had back pain. I've never had it. It's not, I'm an athlete, right? And it's like, well, you're probably a very lateral athlete, and so you're doing a lot of like abduction and stuff. Piriformis just got a little tight, So quick figure four stretch can really go do wonders for a knee varus client. And then knee dominance, the AKA the no butt squat, right? So I squat, right? You see me, like I'm getting low, but like notice how my orientation did not change, and my knees are just going 90 miles an hour past my toes. This is where people are like, yeah, squats hurt my knees. And it's like, again, I've been harping on, we don't have to be afraid of knees going past your toes, but if you're going like, just like I'm squatting, that version of knees past your, yeah, that's going to cause some pain, and that's going to be similar to like jumper's knee. That's going to be a lot of like, oof, that's a lot of quad. Uh, Knee valgus, knee varus, doing the single leg squat, same thing. Depth jump, this again going to be that like rocking forward sensation or like the heels rising. Um, and not coming down. Again, that's that knee dominance. Or we see the valgus or the varus in there as well. And there's all of our specific mobility assessments. We're going over those tomorrow. But yeah, now when we look at this, inhibit, we lengthen, we activate, we integrate. But one thing that's like not mentioned yet, I do want to go back really quickly because I put it in my notes. This is something I added, the Q angle, right? So you do want to make sure if you ever use like an actual protractor and you want to measure this, we look at what's called the Q angle. And it's a little bit different in men and women because obviously like different length, different width pelvises. But what we want to see there is an angle of a certain number of degrees or less. So you can see here, right? If that angle is like really, really wide, right? So like, let's say like 20 degrees, right? That's a sign that like the knees are probably caving in. Bow-legged, we're gonna see almost like no angle, but you don't really have to get a protractor to look at that. You really can just kind of eyeball and like see like what that tracking looks like. Again, if your knee is tracking over your second and third toe, it's in pretty good alignment. But just to tell you how the Q angle works. So this picture kind of helps, but what it actually is you're going to look at, from the ASIS. Let's go. So you're going to go like right here, and then you're going to go center of the kneecap here. And then we have a perfect 90-degree straight line. So that green line that I just drew is perfectly 90 degrees. And then we draw another line from there to there. And then we're measuring this angle right here. That's obviously going to be a little bit wider in women and still be well within healthy ranges. So here to essentially here. Right, again, 90 degrees, and an angle, and the angle is a little bit wider, but it's still like within a healthy range. So a little bit different between men and women there. But again, if your patella is facing directly over, there's the angles I was looking for. If your patella is facing directly over your second and third toe, like right in the middle of the foot, you probably have a healthy Q angle. So that's what we said. We want the knee complex to remain in alignment with the foot and ankle directly over the second and third toe, right between the two. So corrective strategies, again, this one's going to be a bigger list. It's all the general stuff. This is all the stuff you need and you just pick the right ones out from this shopping list here um, for generally knee stuff. But we want to get into, we see valgus, varus, and then heels rise, or we would say like knee dominance. Um, so we really should put that up here in this case. So before we get into that, uh, there. Wait, is that one? Oh God, he's done so many videos. uh, I think maybe it was this one. Let me watch the ankle stuff, hips. Okay, hip airplane. He's doing the touchdown. Where's the touchdown? Oh, he's doing. Okay, okay, yeah, yeah, this one. Usually he does touchdowns on a plate. He's doing it on his squat platform this time. Gotcha. Okay, meow.
Go ahead.